Colibri. No, I apprehensive patient like this, especially young patient. Although she is controlling her eyes very good, I can see she is fixing. But these patients have heightened reflexes and sensory system is also very intact in compared to a 60-year-old male or female. Sensations also go down, neuropathies हो ही जाती हैं. So when I touch, I know that she will move the eye violently up. I know this already. They are very sensitive. They mean young patients. So that is why I'm using a forceps. Usually I don't use a forceps. I make my incision just by knife. So I'm little cautious here because you see if you are putting your keratome at a point and patient moves eye up, now what happens? You have a very short tunnel. Don't have time and that direction that you will travel with the space in the cornea. You will enter nearly perpendicular and this incision is not going to seal. And then you put suture. And you wanted this meridian, which is steep, where you are placing your incision, to relax. And that is why you are keeping the incision on that meridian. And now you have to suture it. So that makes that meridian steep. So instead of relaxing that meridian, you end up tightening it. And a good incision is not only the good start, it will decide your end. If you have a very short incision, the iris prolapses out, iris is traumatized repeatedly, and then it starts secreting prostaglandins, it starts getting small, progressive meiosis, and by the time you are at the point trying to remove cortex, you have a very small pupil, and then you can't see anything, then you pull on the capsule, you catch hold of PC and then you get a rent, and whatever complications you can imagine then can happen. So a good start is not just a good start, is a good end. ये मैंने अभी भी coin किया है ये statement. Is it effective? मैंने अभी भी coin किया. I have not read it anywhere, but I was thinking what should be the good statement to emphasize, and this is good. It's my copyright. So if you tell someone this statement, do tell them that this was coined by me. Not that somebody is going to give me an award for this. We don't have any information about steep axis. So we presume that this is like steep axis with the rule. So we'll place at 90 degrees. आँख ना हिलाइएगा, ऐसे ही देखिएगा. I didn't use the forceps because forceps has its own problems. Forceps will create a conjunctival wound, and it may also cause some hemorrhage. It is so very unsightly. एक सुन की दवा दे रहे हैं, थोड़ा लगेगी. Now when you put in this lignocaine solution intracameral, if you want to punish the patient, then you forcefully inject it and deepen the chamber suddenly, and patient will have nice pain. If you don't want to punish it, do it gradually and just inflate it enough that your pupil is as much dilated as you want it to be. You can overfill it, but that will cause pain. Because till the time intracameral anesthesia has not been delivered, patient will feel all that stretching. Once it is delivered, now if I put this visco and overinflate, she will have no problem because now the iris, ciliary body is all anesthetized. Now when you do RXs in these patients, you should also keep in mind that they have an elastic capsule. So I have nearly switched off the oblique. It is very low illumination, but not that I have a problem. The glow is good enough. You see, it is elastic. Cornea bit karo. Normally in a adult patient, visco दीजिए. Our rexis has gone very peripheral. Still it is in our view. Now, is there any harm in making a very large rhexis?
There's always a risk of extension.
Of course, but any other problem?
If it is stable तो कोई दिक्कत नहीं. Optic पूरा cover रहना चाहिए बस.
इसको दीजिए और is there any harm in doing a very small rhexis? Yes, phimosis is a big problem. We are getting a very eccentric kind of rhexis. इसको दीजिए. Phimosis is common with hydrophilic IOs or hydrophobic IOs? Phobic. I think it is extended way peripheral. इसको दीजिए. लीजिए. Now this is a difficult approach because Vanas cannot cut hair. So I have trimmed that area, but it is still there's a cut hair which is going to periphery. Hydro दीजिए. नहीं. कोई न्यूक्लियस नहीं होगा इनके पास. Like, required piece. We didn't do much hydro because then it will further extend it. Being a myopic, she'll also have a deep AC. Hardly any phaco power is needed. I will. तुम लोग बकल बहुत टाइम लगा रहे हो शुरू करने में. पेशेंट नहीं शिफ्ट हुआ. लोकल लगाओ. आयो नहीं. You must have done some buckles. मेधा कौन करेगा और तुम करोगे? She has done some buckles. Monofocal. EDOF. क्या पावर है?
10. So now to start.
Hmm. You have to make sure that your leading haptic is coming out flat. And for that you may need to rotate supine or prone your hand so that it touches the posterior capsule flat. Young patients have a very good trabecular meshwork. So usually retained visco will not cause as much problem as a adult or a elderly patient. So elderly patient, the trabecular meshwork is all choked. It's like a sieve which has been in use for whatever his age is. No? So it is all choked. So the moment you put something thick in the eye and it has to be flushed away from the trabecular meshwork holes are already clogged, draining his aqueous for rest of his the past life. So they will usually have rise in IOP and slow drainage of aqueous cornea. Although you know that visco drainage is not going to be an issue, but still you should not leave behind. Best, this is the easiest thing you can do to remove the visco rather than post-op giving topical medications.